Welcome to episode 13 of the Future Proof PT podcast. It is hosted by myself, Dana Strauss, and Alex Bendersky. And in this episode, we're going to dive into what is being deemed as a transformative initiative, the Make America Healthy Again initiative, or MAHA, spearheaded by RFK Jr. and Dr. Oz. We're going to explore a little bit about how this initiative says they will aim to revolutionize healthcare in the U.S. by focusing more on prevention, lifestyle changes, and community-based healthcare access, among other things. So we hope that by listening, you gain some insights into the potential impacts of MAHA on the physical therapy community, including the increased demand for preventative services, potentially broader scope of practice, and greater integration into primary care. Alex and I are also going to discuss the importance of therapists embracing their roles as primary care providers for musculoskeletal issues and the real need for a cultural shift within the profession on this issue. We also talk about reimagining the role of physical therapists, emphasizing that need for the culture shift and toward a more proactive and holistic approach to patient care over time. We're also going to highlight the importance of therapists becoming advocates for healthy living and preventive care, and how this shift can really lead to better health outcomes, not just outcomes through the end of a PT episode, and how that is going to contribute to a more sustainable healthcare system. So the episode's packed with valuable information for therapists, even potentially for policymakers who tune in, and anyone interested in the future of healthcare. By the end, we think you'll have a bit of a deeper understanding of how MAHA could reshape the landscape of physical therapy and what steps you can take ahead of this evolving field. And so sit back, relax, get ready to be inspired a little by the possibilities that lie ahead in the Make America Healthy Again initiative. And we will see you in a moment in the show.
Howdy. Well, welcome to the next episode of Future Proof Physical Therapy with myself, Alex Bendersky, and Dana Strauss. And today we will be discussing how to make future proof physical therapy healthy again, or in reality, how to make America healthy again. So I think Dana and I want to take this hour to really talk about the pressing and emerging initiatives in the central government and how it can potentially impact us, the musculoskeletal community, policymakers, and what can we do now through the trenches and what can we do in the future, and how do we recognize this on-ramp and use this as an opportunity to advance our profession. So without any further ado, Dana, would you like to do anything for the introduction?
Sure. And it's always so much fun. We look forward to these conversations and enjoy chatting about them and prepping on our Fun Notion page. So thanks to Alex for always doing such great prep work too. So Make America Healthy Again. I haven't heard too many therapists talking about this. And as I live for these kinds of declarations and enjoy tearing them apart and understanding them and then thinking about how they apply to PT, we thought it would be really fun to chat about this today. And Make America Healthy Again, or MAHA, as I'm sure many listeners have heard in the news, is how Robert F. Kennedy Jr., the new Secretary of Health and Human Services, has coined this phrase to align with President Trump's Make America Great Again moniker. And Dr. Oz, the head of CMS, has also really embraced this. And when we heard from the administration over the last couple of weeks, HHS and CMS and the Innovation Center, they all talked a heck of a lot about what Make America Healthy Again means. And they give cryptic clues about what to expect. And so we kind of have to read between the lines. What we thought, Alex and I thought about talking about today was kind of what Make America Healthy Again could really mean to the PT community. And, how can we think about it in a way that sort of has other therapists, PTs, OTs, STs, anybody thinking about what could be the potential role, and how do we want to start talking about therapy in light of what the government cares about? One last thing I'll say before have you dive into this a little bit more, some of the points that you brought up in prep. When therapists, I think, if you're more kind of aware of what the plans, even if they're kind of loosely sketched out, the plans of the administration, the present administration are, because they're the ones that are like changing rules that really affect us, affect how we're paid, affect the incentives for the providers we depend on for referrals, right? You can craft a different story for yourself and for your business and for your career as a therapist, whether that's clinical or non-clinical. There's so much that we can take away from these clues that are given to us through policymakers that, wherever we can kind of shed some light on that and get discussions going in our community, awesome.
Awesome. Yeah, absolutely. And I think being aware, right, is just that Bayesian reality where using the priors to advance the futures, being hyper aware of where the state of things is today, and using this knowledge to actually advance where we are going as a profession into the future is key, especially when these changes may potentially be profound and fundamental if operated the right way. And so this MAHA, which really, I think, coming from the right place of using policy to change the trajectory of how we approach healthcare from a rather than a reactive into a proactive approach, and using both capital as well as policy making to shift how we consume healthcare in the United States and how we consume other resources to make us better, right? Just if you look into the overall cost, this is not new statistic, but we spend 4 times more than any other country on healthcare. And our outcomes are not even in the top 25. Like we're the 27th healthiest nation in the world, which like it's been said over and over again, but I don't think anyone has ever done anything to act on it, right? We just redundantly mention it and then move on to the next fiscal cycle, and then mention it and then move on to the next. And so it's been a decade of deterioration, and then here we are. Before we even go a little bit into the description of MAHA, I posted an article, I think yesterday, about the report of 10 different Americas from Lancet that has just come out probably a couple of months ago. And it's a brilliant analysis of health outcomes and disparity of health outcomes in the United States based on social and ethnic subgroups. And you can't be blind to the fact that we don't have a single homogeneous United States. We have 10 different United States based on the economic resources and based on social factors. And so I think hopefully this Make America Healthy Again is going to be a way to rise up the subgroup of patient population that doesn't have access and doesn't have accessibility to resources that can make proper positive health changes. So Make America Healthy Again has come out on May 22nd, 2025, and has been revised already twice because there were some edits that needed to be made. The first meeting to get MAHA into a mainframe is taking place today, so it will be actually interesting. By the time this episode comes out, there may be some changes, but the emphasis is really a trifold. There's an emphasis on prevention and lifestyle change. There's an emphasis on payer flexibility to cover for positive health choices, and then there is an emphasis on interdisciplinary and community-based healthcare access and accessibility too. So if you look into those three factors, if you look into the prevention, if you look into that the insurance and payer flexibility and community-based approach, this is really what you and I, Dana, have been speaking about all this time. This is what I think the only fundamental way to make the macroeconomic system transition and pivot in a way that's going to be helpful to the rest of the community, because access, accessibility, and affordability, right? Those are the three things that we need to provide to the general populace, not just to part of the populace, to make this viable. But with that in mind, I will kind of throw a question to you. These are all grandiose assumptions, but grandiose assumptions are great at creating these large slogans and large tokens, but rarely result in fundamental change on a grassroots level, right? So I always like that transition between the macroeconomic level and the microeconomic level. And the macroeconomic level, yes, let's make America healthy. Let's get prevention. But on a microeconomic level, what do you think is the probability that in the next 2 to 3 years it actually will have an impact on a daily operation of a standard, let's use musculoskeletal care because that's where we are, right? But musculoskeletal function, what's the probability of this actually trickling down to be impactful for day-to-day operators in the field?
So, yeah, good question and not so simple answer. But I think part of how this is going to impact musculoskeletal care and how therapists practice is partially going to depend on the voice that therapists bring to this. So, to dig into sort of what they mean by prevention a little bit more, the right primary prevention is just like staying within a healthy BMI, not smoking, right? Secondary prevention, identifying diseases early, colonoscopies, so we get colon cancer early, et cetera. And then that tertiary is a lot of what we deal with, tertiary prevention. I'm happy, first of all, that they're using this term for prevention, where tertiary prevention means managing chronic diseases better. For musculoskeletal care or movement, there's a whole lot that we do that impacts the management of chronic disease. And it goes beyond musculoskeletal care, but it's a simple, right? Very simple to think about something like osteoarthritis and low back pain as just two big broad categories where there's tons of spend that isn't necessarily valuable and can sometimes actually be harmful, and the only fractional role that we're playing right now. So when we think about what's the role for therapists, part of, I think, what we're going to be watching out for are ways that CMS and the Innovation Center change incentives. And they have a lot of tools for doing this. One of the ways they do this is by creating a payment model, which becomes a care model essentially, and then mandating that model for participation and making the lack of engagement in the model fiscally painful for participants. So they can create a model where there is, let's go to CJR is the real common one, that the comprehensive care for joint replacement. It was mandated in a lot of parts of the country. We've talked about it before. And it has a 20% downside risk potential, which means the organization or the providers that are in the model, if they don't provide provide good care, good outcomes, and they spend more than expected, they are at risk for then having to pay back the government for that longitudinal outcome that wasn't at least at a bar that is expected for kind of good care. There's lots of ways to describe it, but I think that's a relatively simple one. They can create a model, for example, that is longitudinal for osteoarthritis, right? An episode of care could be a whole year, could be multiple years, and then insert upon that an episode for surgical intervention or other intervention. So it's kind of like a building blocks, right? That's something we could see. Will we? Don't know. But if a model like that is created, right, therapists have the ability to be vocal and participate, even if they're not the ones that a model is directly focused on. Therapists, just like any other organization, can go to the organization that's at risk, if it's the hospital or if it's a physician practice, and say, hey, we're willing to participate with you. And we're seeing this in the transforming episode accountability model also already, which is coming out in January. So in that respect, we're going to see it no matter what, starting in 2026. Are therapists going to participate? But that's when we talk about something really tangible. What do we mean by what could the government do? They can create a model like the team model and then say, you are going to be responsible, you hospital, and now you have to figure out how to transform how you provide care and who you partner with so that you can be successful and not owe us money. I mean, that's the bottom line. So, will we see it in the next couple of years? I think therapists that actively go out and seek partnerships to help organizations that are either mandated to participate in a program or have chosen to participate in a program because they think they can be successful, understand how the models work, and then offer our professional services to help them be successful, and then figure out how they can reward us for doing a good job. And that is something that you can start tomorrow. And I'll stop.
Absolutely. No, I think that's very well articulated, Dana. And I think that I'm going to give a shout out to Cody Lee, Dr. Cody Lee, and his use of large language models, right? So I loaded all of the White House supported and White House issued documents into Notebook LLM. And so this is a cool free tool that we can use. And then you can ask it questions. So that, like, the unique feature of that Notebook LLM compared to some of the other language models is that this one is interactive, where you start asking questions and it's like like you're having a conversation with someone who has now a profound understanding in this Make America Healthy Again. So the question was that what is the potential impact on the physical therapy community? And based on the document, the way it's written right now, there's four factors that will impact the physical therapy community. One is that there's going to be an increased demand for preventive services. So, and we'll go a little bit deeper into it. The second point is that there's going to be a potentially a broader scope of practice. It's just going to be an expansion of physical therapy practice from the current Practice Act to potentially covering other diagnoses, other episodes of care, or more maybe an extended episode of care. There's going to be greater integration into primary care. And I know you and I have covered this extensively, right? Is that physical therapist as a primary care provider for musculoskeletal problems. There's an opportunity in urgent care and emergency room. There's an opportunity to be integrated into this primary care, physical therapist, behavioral therapist model. So there's all the scope of opportunities, but the opportunities need financing, and this potential will provide revenue or currency for financing. And then there's a potential for policy and advocacy of expansion, that the policy is going to, and advocacy, we will have the capacity to expand just the role, right, that we play in an entire healthcare ecosystem. So let's go dive a little bit deeper into that preventative services. I think these labels, prevention, needs to be clearly benchmarked because to me, and I think to at least a part of this informed community, prevention is more of a negative connotation than a positive connotation. Prevention has been used indiscriminately for the last 20 to 30 years to really mean nonsense, right? Oh, they're just doing prevention care. Like they're not doing legitimate care. Because prevention has never been clearly labeled to have mean something substantial. It's not, without substantiation, prevention is vapor, it's ether. But with substantiation, prevention is, as you were mentioning, good lifestyle choices, right? Like working on your social determinants of health, working on your functional activities, working on your mobility. So there's a lot of prevention. I think with APTA hopefully taking some leadership in this, where they will clearly label what prevention means to the musculoskeletal community. The prevention mobility, prevention sedentarism, prevention joint health. Like that prevention needs to be very clearly labeled and defined so that we can then monetize it and actually create products and lines of products that work on this prevention as a well-defined label. So I'll throw it back to you with this.
I completely agree. I really hope that the APTA leans into this and leans into collaborating, working with CMS to help better define the what roles therapy can play. I'm going to go out on a limb here and say we're going to start seeing along these lines, along the lines of as we define and reimagine prevention as something really positive that can impact, health outcomes long term and impact healthcare spend. So we start to see that equation looking better, that the stakeholders that we should be thinking a bit about in terms of like who cares about this, the investor community, we're starting to see a lot more interest in um, getting a piece of the pie for musculoskeletal care. More that obviously we are all familiar with the MSK Hinge Health and Limber Health that just got acquired. And Taylor Care and other organizations that are providing some combination of care navigation, more therapist centric, RTM, like we've spoken about, that are trying to take that, extract that value that therapists have within their scope and their expertise, and take that value and use it to pull spend out of the high cost parts of the care continuum, bring them into the outpatient setting and keep more patients home. That's the big theme I'd love for therapists to pay a whole lot of attention to. Real broad theme is the way to save money is don't let people go to the hospital. The way to save money is to keep them home safely. The way to save money is to address, of course, access and touch more patients for the right amount of time and keep them well and safe in their homes, address their pain, and keep them away from what's not necessary in terms of more interventional care. We are great we know this. We're great at knowing who really needs to see a surgeon and who doesn't. We're way better at it than primary care providers are by and large, right? We're way better at it. Where can we, this is, I think, how we have policymakers likely thinking, certainly the investor community is thinking. How can we get the expert therapy community in front of more patients that have needs that can be addressed by the very high value therapy community and keep them away from opioids and surgeries and imaging and interventions and injections that are not necessary medically. There's a difference between avoiding care and avoiding unnecessary care and avoidable care. This is the crux of what therapists have in our toolbox that we have to start sharing with people with the incentive to care. And now that's a theme we've talked about, and I've written about quite a bit too. We get on, I notice therapists get on this high horse about, well, they should just understand, right? Hey, everyone should just get it just because we have direct access. That's nice and well and good, but we got to get out of that ideal world. People only care about what hits their own pocketbook. And when there is an incentive to care about getting folks to really high value care like therapy to avoid other care that's lower value, higher cost, and more variable, now we know who we should be collaborating with because they have the incentive to care. Anybody who is financially impacted by us having a bigger stake in the entire healthcare pie is who we should be talking to. And the rest of it is noise that we've become just too comfortable with. And it is clearly not moving the needle significantly.
Yeah,
I
yeah.
over answered that, but I couldn't help
No,
myself.
no, that was brilliant. I think that's right on, and I think that's one thing to beat yourself in the chest and to say they should understand me, they should care, right? But nothing changes when nothing changes, and when you're only looking to self-validate without seeing a bigger picture, that is probably one of the biggest, the cusp of errors of physical therapy community and APTA to this point is not seeing that trajectories and actually just being reactive towards what has been done. There's two books that I think we'll share in our notes afterwards that can we can learn from. And one book is called The Inventors, and it's from Walter Isaacson, and it's really the story of computing industry and computers from the last 200 years, based on the innovators. Maybe it's the innovators, sorry. But the point is, it's like that we're all standing on the shoulders of giants, right? So when you look into these fundamental changes, like America Healthy Again, it didn't come from nothing. It came from years and decades of inference and inquiry into the healthcare spend, into the outcome-based propositions, and there's now an understanding that potentially making a financial investment into these, again, I hate to use the word prevention, but using it into these positive resources can have an impact on a downstream effect, on a downstream spend, on the health outcomes. Certainly, someone having the capacity to get a dental visit, right, like a dental checkup, where this country is actually awful in terms of access to dental care, is going to have a significant downstream impact, not just in oral health, but in general health, right? So maybe that an ounce of prevention is worth a pound of care. That ounce of prevention in oral health services is going to be worth a pound in cardiac services in
Mhm.
10 years, because there's direct correlation, health correlation. The second book is, I think, just for the musculoskeletal stakeholders, if they want to learn on how to build a fundamentals of an industry. There's a book about Jeff Bezos and how he built Amazon based on his letters to stakeholders that I think started in 98, then goes through like 2020. But you can see his thought and the process and the trial and error and the risk proposition, but seeing that like a larger picture to what is going to be needed. I think Bezos in 1998 already knew what Amazon is going to look like in 2020, but he built it over years of trial and error and experimentation. When you are a musculoskeletal stakeholder and you see something like MAHA that comes on the market, regardless of your political denomination, you have to see this as an opportunity because
Mhm.
this is big and this impacts your practice act directly. This is where physical therapy is primed to contribute because we have the skill set, we have the capacity, we have the framework, and we have the manpower or person power now to contribute down the line. We have 270 well bodied, capable professionals in United States that can take over some of the shortages and some of the positive care in United States and carry it forward by clearly labeling prevention, by expanding the scope of practice, by integrating into primary care. But this needs to be done in a way that's calculated. This needs to be done in a way that doesn't just see a trajectory in next year, but sees the down map in 5 years and 10 years and 15 years. And that's the thinking we need to adopt as a musculoskeletal community, that not do what do we do next quarter to increase our profitability, but what do we do that will help us become viable in 2027 and 2029. And that type of thinking will definitely result in a much higher level of practice and a much more pertinent capacity and power within a larger healthcare system. So that's my take on this.
Mm. I love the way you've thought this through. And just going back to the LLM and how you used Cody's, Lee's, frameworks for using something like Google Notebook to synthesize information and help as a thought partner is really smart. And I love all the things that you described. One of the things that for whatever reason, popped up for me when you were talking about this was the difference between discharge and transition. And it sounds like, oh, that's such a boring, like hokey topic, but I think it's so pertinent to what you just described in terms of something like how you work with a dentist over time and having this partnership with a professional who across potentially the decades. I don't know about you, but I've been going to the same dentist for decades, and my appointments with him every 6 months are that touch base where I know this important component of my health is being monitored by an expert, that I commit, whatever it is, the between the insurance and seeing him and the time, maybe $1,000 a year, but it's incredibly important investment. We have an opportunity here to be thinking about how therapy is an investment and not something that's, something like a price that can't be controlled. We've constructed therapy as something that's like this big commitment. If we rethink about therapy as we're your partners through life and we're here for you when you need us, and we're here for check-ins so that you can count on this big component of your body being managed to help you as a partner to manage that and coach you along through life, just the same way our dentists and hygienists do, right? Going back to discharge and transition, one of the things that when working in a health system across the continuum of care with a team in population health that was trying to help our patients have better outcomes and get them home safely after a hospitalization. One of the things I would talk to therapy departments a lot about was like, your role is not discharge planning as much as you've been, brainwashed, for lack of a better word, into thinking it's about, quote, discharge planning from day one. It's not really. And it doesn't matter where you sit, it's about transitioning patients to what is next. And if we can reimagine the therapist's role, whether it's in an episode or through the course, a continuum of life, as being a partner and helping them transition in and out of episodes of care and transition through stages of their life where they may need us more or less for different things, as really like the same way we think about we have a PCP that we see annually at least, and we have our dentist. If we can position ourselves in either those acute episodes or in our work in the community as a long-term partnership and use that language with our patients and their families, depending on the site of care we're working in, we can then begin to position and change the perception of what the public thinks therapists do and are and what our profession stands for. Because I would argue, and I'd love to then hear what you think about this, I think one of the ways we've stabbed ourselves, our own selves in our own profession in the gut is by not positioning ourselves as a partner through the course of time between episodes of care, but then, over time as someone that when I say, like, who is your PCP? Can you recommend them? I'm looking for someone to that it will be norm for the community the culture to be, I need a physical therapist as part of my care team as one of 3 or 4 people that's, through life, and understanding, and this was really the point of where I think we're stabbing ourselves, understanding that it's the culture that has to change, which is going to be little by little by little, everyone getting on board, as many of us, a groundswell of changing our perspective that we are there to fill a prescription or to address acute need and to discharge, get ready to discharge a patient, and more the culture of we are here for you. You have us as a partner. If we don't, as a group, think differently about the role of the profession at the 30,000-foot view. It doesn't matter how many times we say payers or other providers or anybody else should value us more. It just doesn't, it's not going to matter. It's about that core fundamental change in what is a physical therapist or a physical therapy professional to the larger healthcare community and to each individual human being who needs our care and our partnership throughout their lifetime.
In the words of an ancient philosopher, Matthew McConaughey, all right, all right, all right. Right on, Dana. I think that like the culture is a fundamental trait that I would be critical of in our profession. And I would go to like I know this old sore point of mine where physical therapists that finished DPT need to systematically refer to themselves as doctors when they are in the professional setting. They are doctors of their profession. They are doctors of physical therapy. It's not a pretense of being anything else. It's not a pretense of being encroaching on somebody else's professionalism. But as soon as we start to systematically adopt that we are doctors of our trade, when we introduce ourselves as Dr. So and so, when we are onboarding a patient into an episode of care, that's what culture is going to begin to change. And that has to come from the top. It has to come from trenches. You are a doctoring profession, and that goes into a deeper fundamentals where there is a skill economy, and then there's the expert economy. And when you're a doctor of your profession, you start practicing expert economics. Expert economics, you're valued for your knowledge and your expertise. Skill economics, you're valued for your skill set. Right now, physical therapists practicing below their license who are afraid of referring to themselves as Dr. So and so are practicing skills. They're not practicing expertise. You have to be comfortable and confident to refer yourself as a doctoring trade, as a doctoring profession, in order to participate in this larger ecosystem of being a primary care provider for musculoskeletal care, being able to engage in a larger healthcare community. So that really is fundamental to be comfortable and confident in your knowledge and in your setting, and being comfortable and confident when you do graduate from a DPT program. You have to hope that CAPTA made sure that your fundamental knowledge, baseline knowledge, is such that you are capable of managing an appropriate patient with a musculoskeletal or neurological or vestibular disorder from point of onboarding to the point of completion of care for that episode of care, but do not discharge. Discharge is something that comes out of your wound when it's infected. Discharge should not be occurring in any form of physical therapy. It's ridiculous. It's a fallacy to discharge someone. You're essentially telling your patient that entrusted you with their care that I no longer want to see you. I'm divorcing you. I am separating myself from you because you are discharged. Go seek something else or someone else. You can complete an episode of care, but you need to maintain a role of being a musculoskeletal expert in that person's life. And that is essential. Without us taking that expertise, we're traders, right? We are traders, which is great. We have a skill set and we can apply that skill set indiscriminately over and over again. But that's what causes the burnout. 5 years, 10 years, 15 years into your profession, here you are. What do I do next? How do I find this next sales position so I can start peddling services or peddling products because I'm going to get paid a little bit more for it? Because you never really embraced the expert economics of your profession. You never started doctoring and doctoring on the physical therapy terms. So I really think that's fundamental for us. Like, if nothing else, stand in front of the mirror on Saturday morning and say, I am a doctor of physical therapy. And again, this is not to discriminate or to belittle someone who has been practicing for a while and may have never gotten that transitional doctorate. But at this state, DPT is the baseline entry-level professional setting. This is what you need to practice. So any of you out there that has been out of school for less than 10 years, you certainly have a DPT. You need to regurgitate that you are in a doctoring profession. There's a skill economics, there's expert economics. You are an expert of your trade, whether you like it or not. And the only way to diminish that is for you to downgrade yourself into skill economics by doing the same redundant things, by not practicing on top of your license, by not investing in your profession, by not taking continual education courses that actually lift you up and lift your knowledge base up, by not inferring and looking into these emerging technology resources like Cody has, right? Like so many others have, and by just diminishing your importance. If that happens, Dana, I'm confident that our entire profession will be able to handle some of the responsibility that potentially will be entrusted in us by some of these acts like MAHA and hopefully some of the other acts that are emerging. So, and
This
I
is
was
an
preaching here.
opportunity for us, right? Like, I couldn't agree with you obviously more, but this is a huge opportunity for us. This has nothing to do with politics. It doesn't matter. It was irrelevant. I think sometimes what I suspect is that when someone's in office or certain political parties in power, if we don't agree with them, we just turn off what they're saying. But that, right, that is the worst way to engage in policy, understanding that it doesn't matter who's in power. The policies that they put forward are going to impact you. It has nothing to do with whether or not you agree with anything. It's you should be as any healthcare provider, because we are so heavily regulated and by government policy, right? Federal, especially federal, but it also is at the state level. I mean, if you think about at least CMS being a federal program, you should know what they're saying and be thinking about, just like all the people who want to make money off of this are doing, be thinking about, well, what could that mean? How can I talk about the work that I do in a way that'll resonate with this, since this philosophy is the direction we're going for the next couple of years at least? And especially now with the framework of MAHA being something that we can absolutely simply present the therapy professions as a solution for, we should be embracing every last bit of it that we possibly can. I have to say one other thing about discharge to really hammer this point home. Would you ever go to your PCP or your dentist and have them say, "You are discharged. You are discharged from care. Goodbye." Right? Please, everyone, get that out of your nomenclature. And I want to bring an example that Paul Singh uses on Strata. He's used it a couple of times, as I've heard, and I really think it resonates. He talks about, he's a runner, and when he goes to see his physical therapist, sometimes twice a year, he's calculated about it's 6 or 7 visits, whatever it is. But the value of him as an individual to this practice is what, $1,000 to $2,000 a year. That trusted relationship, just at a baseline, is worth to that practice that amount. And that's a baseline for thinking about how anyone, if they imagine you as their trusted partner in managing their musculoskeletal care, can begin to imagine you are their quarterback. Think of it this way: their quarterback for musculoskeletal care. We can't afford for orthopedists to be a quarterback. They've taken that role because we've allowed them to.
Yeah.
But they have a very important role to play, but it is not as great as the role that they're playing now. We are the ones with the ability to be a quarterback. Doesn't mean we can't be specialists also, but we have to
100%.
embrace the quarterback so that we can then lift up all of this incredible specialist expertise. I've used this before, but pelvic health therapist, right? We have a pelvic health PTs and OTs are experts that provide specialist care, and we can help lift up that specialty by being viewed by the public differently as their partners through their lifetime. And again, I agree, embracing that doctoring role is so, I always did, and I had a master's degree only until for 22 years. I only had them because that's all they had when I graduated. I didn't go, I wasn't even practicing anywhere near full time when I got my transitional DPT, but I felt like it was my responsibility. If I wanted to continue to call myself a PT, and that was my professional designation, that I owed it to the profession and to anybody whom I would touch later to make sure my knowledge level was up at that doctoring level. Did I think after going through it, I had 95% of it already with an extensive, robust master's program. So I imagine myself that, but it doesn't matter. It's what the public thinks.
Yeah.
So that transitional doctorate's going to be gone eventually. I'm surprised it's still around. For any of you like me, old folks who graduated in the 90s, go back and get your doctorate if you're still practicing therapy. It doesn't take that long. And boy, the profession needs us all to be at speaking like that. I went to the pharmacy yesterday. The
Yeah.
pharmacist he calls himself, he's a PharmD, calls himself doctor, right? But it says Dr. So and so, PharmD. So we're Dr. Dana Strauss, DPT. We're not saying we're physicians. Everybody get on board with this. Enough's enough.
Yeah. And you hate to say it, but it still is a feudal system. There's still a hierarchy of responsibility, and there's a public appreciation of your level of training based on your introduction, based on the tag on your name tag conveys a lot to your consumer about your level of training. So your approach, your demeanor, the way you carry yourself is exponentially important. And yes, it may be a little belittling somewhat the importance of skills and the importance of knowledge. But truthfully, there is that book by the cover, right? Judge the book by the cover, that the contextual factors impact social reception of who we are and how we practice. So it is an anecdote, and I know you've used it here too. There was a white coat experiment where they had graduate students taking a math test, put on a white coat, right? And half were told that this is a painter's cloak, and half were told this is a PhD student's coat. And they looked into that outcomes. The ones that thought that they're wearing a PhD student's coat did better in the math test than the ones that thought they were using a painter's coat. If you introduce yourself as a painter, if you carry yourself with a demeanor that I'm just a physical therapist, let's get on the bicycle so I can finish my notes, it carries a very different contextual reception by the patient than if you are a physical therapist like Paul, who went to his physical therapist, who carries expertise, who can answer some questions that he has, and he's making that $4,000 a year investment that through the episode of care for knowledge, right? It's an equal economic transference of knowledge against currency, where I'm going to pay you money, so you give me reassurance, you give me expertise, or you direct me in a way where I can invest some more currency to get the answers that I'm looking for. And it's transactional, right? And we don't want to see that healthcare is transactional, but it really is. So when you say I'm a Dr. Alex physical therapist, my price just goes up because that contextual label introduces me as someone who has gone through 7 years of school and who has at least baseline understanding of this musculoskeletal problem that will direct you. So, and then somebody receiving my care is no longer just doing exercise and no longer just being massaged, right? Then that manual therapy skill carries a much higher value. The exercise prescription carries a much higher value. The advice carries a much higher value just because of how contextually I introduce myself. So yes, it's important. And yes, community, embrace it. Take it for what it is because it's important for us to elevate. So just because we have limited time, I want to go into some of the potential drawbacks of MAHA, and we should definitely discuss it. So there's three risk factors that are associated with Make America Healthy Again. And the first risk factor is the impact it may have on reimbursement, physical therapy reimbursement especially. The second risk factor is resources. Do we have the capacity and resources to answer some of the calls? And then the third potential risk is our ability to collect outcomes. And I know we've spoken about this, but outcomes, right? So first, let's talk about reimbursement. We have been, especially in a fee-for-service model, we've discussed this before. We have been struggling to justify the value that we provide to the consumer because certainly the fee-for-service and the payers have been diminishing our value through the cuts in reimbursement over the last 10 years. So when someone comes out with a larger overarching theme of prevention, they may say, well, the value of prevention is only $20 per episode of care, right, or per encounter. And who's to stop it unless we have the right legislation and the right lobby to say that, well, now you're going to be seeing 300 million consumers, but we're only going to pay you $20 per encounter. And that's a problem, right? The second part, that training and resources, do we have the capacity to train our staff to provide this type of care, right? Like, are we where we need to be, or do we need to make adjustments so we can get there by the time MAHA is actually fundamentally viable? And the third part is data and outcomes. We suck at keeping data and we suck at tracking outcomes. We just don't do a good job. And you just mentioned Limber was just acquired by NetHealth. Now NetHealth has Photo and Limber. It has two fundamentally positive, I think, data collectors in a musculoskeletal field. What are they going to do with it? Like, are we using it indiscriminately? To best of my knowledge, to the best of my expertise and experience, we're still using outcome measures as something we have to do, right? Nobody's looking at outcome measures as a way to guide patient-centric progress. We're using outcome measures as a formality. I just like, here's your history, fill it out so I can get on with my life, right? Data is important. Outcomes are important. A little plug, and you may cut this away too, but Dana, happy birthday, you.
Thanks.
It's your birthday, well, yesterday, but you're awesome. I think every conversation we have is a privilege, and happy birthday, and I wish you celebrate and all the best, dude.
Thank you. Thank you. It's so much fun. Thank you all for joining us for this episode of Future Proof PT. I'm Dana Strauss, and Alex and I have thoroughly enjoyed exploring how the Make America Healthy Again initiative could transform our profession if we have the right mindset. As physical therapists, we do have an unprecedented opportunity to position ourselves as the MSK experts and lifetime health partners our patients truly need. So whether you're a clinic owner, a staff PT, or a student, now is the time to embrace your doctoral identity and elevate how you present yourselves to patients. And remember, stop quote unquote discharging patients and start building lifelong relationships. Prepare your practice for the prevention focused future that's rapidly approaching. If you found value in today's discussion, please share this episode with a colleague. Leave us a 5-star review and let us know what topics you'd like us to cover in future episodes. And until next time, this is Dana Strauss, and Alex Bendersky and I are encouraging you to stay future-proof in your physical therapy practice and your professional career. So long for now.